Hello friends, today I will discuss about Cushing syndrome. Cushing syndrome is a constellation of clinical features in a person due to chronic exposure to excess glucocorticoids because of any etiology. It could be due to increased production in our body, which is called endogenous, that is pituitary tumor which can secrete ACTH, which can ultimately lead to increased cortisol production in our body, and adrenal tumors which may directly produce excess serum cortisol. It is considered exogenous cause if the steroids are administered from outside, like in the form of therapy. Usually, steroids are given for long term in case of autoimmune diseases like SLE, rheumatoid arthritis, etc., who are prone to develop Cushing syndrome. And coming to the incidence, Cushing syndrome per se is very rare condition. It is seen in only 1 to 2% among 1 lakh population. And remember, exogenous causes are the most common. It is also called iatrogenic causes or drug induced. Okay, see, this is the most common, much more common than the endogenous causes, right? But among the endogenous causes, pituitary tumor is the most common cause of Cushing syndrome, accounting for 75% of cases of endogenous Cushing syndrome. Okay, let's discuss about the regulation of hypothalamic pituitary adrenal axis, which is HPA axis. Okay, usually in response to the circadian rhythms and stressors like physical, emotional, and including fever, hypoglycemia, and hypotension, what happens, there is a release of neurotransmitters in the hypothalamus, which helps the hypothalamus to secrete corticotropin releasing hormone. This corticotropin releasing hormone activates the anterior pituitary to produce ACTH, which in turn releases into the circulation and activates the adrenal cortex to produce serum cortisol. Okay, this is how the cortisol is formed, and after that, once adequate cortisol is formed, what happens, it negatively inhibits the release of corticotropin releasing hormone from the hypothalamus as well as ACTH release from the hypothalamus. So in this way, the normal cortisol level is maintained in our body, and these factors like stresses and circadian rhythm, all these are helpful in maintaining an adequate amount of cortisol in our body. So whenever there is an imbalance in this cycle, there could be increased cortisol production or decreased cortisol production. So for example, if the hypothalamus starts secreting more corticotropin releasing hormone, it can ultimately cause increased cortisol production. That is the one cause of Cushing syndrome. The other cause is increased production of ACTH, which in turn leads to increased cortisol production, right? Or otherwise, the adrenal gland itself can produce more amount of cortisol without the help of ACTH, which is called ACTH independent disease. If the increased cortisol is because of increased ACTH production from the pituitary gland, then it is called as ACTH dependent Cushing syndrome. Coming to the various causes of Cushing syndrome, ACTH dependent Cushing syndrome is the most common one, accounting for nearly 90% of the cases. Okay, pituitary adenoma is seen in 75% of cases, whereas ectopic ACTH is a common cause in 15% of cases. Whereas the female is to male ratio is 4:1 with pituitary adenoma, whereas it is only 1:1, that is equally common in both males and female in case of ectopic ACTH. If the cause is pituitary adenoma, then it is called as Cushing disease. Remember, Cushing syndrome and Cushing disease is different. The Cushing syndrome because of pituitary adenoma is called as Cushing disease. Okay, coming to the ectopic ACTH. Ectopic ACTH means ACTH produced by any other structure other than pituitary. Normally, ACTH has to be produced in pituitary. If it is produced by any other structures, then it is called ectopic ACTH production. And the causes are usually tumors like carcinoid tumors present in thymus, pancreas, or gut, okay, or lungs also, or bronchial carcinoid. Okay, other things are small cell lung cancer. Small cell lung cancer can produce ectopic ACTH, and also medullary carcinoma of thyroid. Medullary carcinoma of thyroid, and also pheochromocytoma. Pheochromocytoma can also produce ectopic ACTH in addition to the catecholamines. Okay. Coming to the next category, ACTH independent Cushing's, that is direct production of cortisol from the adrenal gland itself. So this could be because of adrenal adenoma, adrenocortical adenoma, or adrenocortical carcinoma, or other rare causes. The ACTH independent Cushing's is also more common in females and accounts for about 10%. Okay, adrenal cortical adenoma is seen in 5 to 10% of patients, and adrenocortical carcinoma in 1% of patients, and less than 1% account for other rare causes, which include macronodular adrenal hyperplasia, primary pigmentary nodular adrenal disease. These are all very rare causes of Cushing syndrome. Okay, and McCune Albright syndrome. So these are the various causes of Cushing syndrome that we need to remember, and we need to remember that the Cushing's disease is the most common cause, accounting for nearly 75% of the cases. Okay, both 75 plus 15 it together constitute the 90%, which is the ACTH dependent. Okay, only 10% are ACTH independent cases, right? So coming to the clinical features, before we discuss the clinical features, we need to know what are the physiological effects of increased cortisol. Right? Increased cortisol causes gluconeogenesis, leading to increased glucose in our body, so it can lead to diabetes, increased lipolysis, and increased protein breakdown, leading to myopathy and muscle weakness. Okay, the increased lipolysis causes redistribution of fats. And dyslipidemia. So excess melanocorticoid action of the cortisol leads to diastolic hypertension. Remember, it is a diastolic hypertension which is much more pathogenic in this Cushing syndrome, and it is associated with the hypokalemia because of more mineralocorticoid action. That means more aldosterone, more hypokalemia, right? And also edema because of sodium and water retention. It causes edema of the patient. So excess glucocorticoid action also interfere with central regulatory system, leading to suppression of gonadotropins with subsequent hypogonadism and amenorrhea in case of females. Right? And the other things it can cause is obesity, predominantly central obesity. And there is distribution of fat over the nape of the neck region, leading to buffalo hump appearance of the patient. The patient will also have moon face appearance, okay, because of facial puffiness and fat redistribution. They will have central obesity, buffalo hump at the back, and moon face. Okay, as I already explained, increased gluconeogenesis leads to increased sugars, and these patients are at risk of glucose intolerance and type 2 diabetes mellitus. They also have diastolic hypertension, and because of diabetes and hypertension, there is increased risk of cardiovascular mortality. And this patient, because of excess androgens, usually in females, it can produce hirsutism, and excess steroid can cause psychological disturbance in the form of anxiety or depression. And because of proteolysis, there is increased skin fragility with easy bruising, and broad, that means more than 1 centimeter broad purplish striae are seen over the abdomen. They are purplish because of increased vasculature, whereas in striae due to obesity, they are pale in color, they are not vascular, so they are not purple in color. But in Cushing syndrome, because of increase in the vasculature and increase in the skin fragility, they appear purplish. Okay, and proximal myopathy, especially the patient present with difficulty in climbing stairs because of proximal myopathy. And in ectopic ACTH production, we can differentiate clinically. It is very hard to differentiate between whether ectopic ACTH production or pituitary ACTH production. But one finding which is prominent in ectopic ACTH is there is hyperpigmentation of the knuckles, scars, or skin areas exposed to friction or observed because of the increase in ACTH is much more when compared with pituitary ACTH production. And also because of POMC, increased POMC causes increased melanin deposition in the skin creases and also skin areas exposed to friction, right? In ectopic ACTH, clinically the onset of the disease is very brisk, sudden onset, and they rapidly progress with prominent clinical signs and symptoms. But remember, if the ectopic ACTH production is because of malignancy, then the patient may not have this obesity because underlying malignancy can cause cachexia, right? And a hypercoagulable state. These patients are prone to develop hypercoagulable state, and there is increased risk of both DVT and pulmonary thromboembolism. And coming to the osteoporosis, the patients are at risk of developing vertebral fractures. Okay, the increased cortisol increase the risk of osteoporosis, and it should be treated similar to other conditions where we see osteoporosis. So let's discuss the diagnostic algorithm of Cushing syndrome. When you suspect clinically a patient is having Cushing syndrome because of clinical manifestations like obesity, hypertension, okay, then we need to confirm. The first step is we need to confirm the diagnosis or screen the diagnosis, right? So the first investigation we can do is 24 hours urinary free cortisol excretion, which is increased above the normal, usually more than 3 times. It is considered positive. And we can also do dexamethasone overnight test, in which at 11 p.m. we can give 1 mg dexamethasone to a patient. On the next day at 8 to 9 am, if we measure the serum cortisol, it should be more than 50 nanomole per liter. 50 nanomole per liter. Then the test is considered positive. Okay. And in addition, we can also do midnight plasma cortisol level, which should be more than 130 nanomole per liter. Or we can also use midnight salivary cortisol. If more than 5 nanomoles per liter, it also indicates the patient is having Cushing syndrome. So if these tests are consistently positive, it indicates the patient is having Cushing syndrome. And then we need to differentiate whether it is ACTH dependent Cushing's or whether it ACTH independent Cushing's, right? So for that we need to measure ACTH levels. If the ACTH levels are normal or increase, then it is ACTH dependent Cushing syndrome. If the ACTH is suppressed to less than 5 picogram per milliliter, it indicates ACTH independent Cushing's. So for example, suppose if ACTH is normal or increased, then the next step is to check whether it is pituitary ACTH or ectopic ACTH, right? For that we need to do MRI pituitary. If the MRI pituitary is showing mass, then it is mostly pituitary adenoma. But remember, most of the adenomas are very small. Adenomas are very small and they are easily missed. Even around 90% of pituitary adenomas leading to Cushing syndrome are microadenomas. That is less than 1 centimeter or just few millimeters in size. Okay, only 10% of them are macroadenomas. Okay, so the mammary pituitary may not pick the diagnosis always. So if the MRI pituitary is normal, doesn't rule out that pituitary is not cause for Cushing syndrome. Okay, and we can do this corticotropin releasing hormone test, in which the ACTH increased by more than 40%. The increase ACTH more than 40% at 15 to 30 minutes plus cortisol increase more than 20% at 45 to 60 minutes. Both these are after CRH 100 micrograms IV stat. Okay, the other test we can use is high dose dexamethasone suppression test, in which 2 mg dexa is given to the patient 6 hourly for 2 days. For 2 days we need to give the patient 2 mg dexa 6 hourly, and then if the cortisol suppression is more than 50% suppressed, then it is considered positive test. So if any of this is positive, the diagnosis is Cushing's disease. If the MRI pituitary is positive, it is Cushing's. If CRS test is positive, it is Cushing's. And a high dose dexamethasone test is positive, it is Cushing's disease. Okay. If the results are equivocal, we need to do further testing. Okay. But if it is negative, if the tests are negative, then the cause is ectopic ACTH, and which can be further confirmed by doing inferior petrosal sinus sampling. Okay, so if the patient is found to have Cushing disease, so the ultimate treatment option is transsphenoidal pituitary surgery. Okay, but in case of equivocal results, if the results are equivocal, then we need to do inferior petrosal sinus sampling. So bilateral, we need to do bilateral inferior petrosal venous sinus sampling. Usually it is done by a specialist. And after doing this, if the petrosal by peripheral ACTH ratio is more than 2 at baseline or more than 3 at 2 to 5 minutes after giving CRH 100 micrograms intravenously. So if the ratio is more than 2 at baseline, or if more than 3 at 2 to 5 minutes after giving CRH 100 micrograms IV, the test is considered positive. Okay, the test is considered positive. It indicates that the reason is pituitary. The reason is pituitary gland, which is secreting the ACTH, and the diagnosis is Cushing's disease, and the treatment is transsphenoidal pituitary surgery. However, if the test is negative, the pituitary, MRI pituitary is negative, everything is negative, then we need to look out for ectopic cause of ACTH, right? So for that, we need to locate and remove the ectopic ACTH source. We can do CT scan, chest, X-rays and everything to rule out the ectopic source of ACTH. On the other side, after confirmation of Cushing's disease, and if ACTH is low, it is called ACTH independent Cushing's, and the first line investigation we need to do is non-contrast or unenhanced CT adrenal glands. Okay, if the CT adrenal glands, there are two terms. It could be unilateral adrenal mass, or there could be bilateral micro or macronodular adrenal hyperplasia. If bilateral adrenal gland hyperplasia is present, we need to remove both the adrenal glands and followed by steroid supplementation for lifelong. Okay, for unilateral adrenal mass, we need to do adrenal tumor workup, but biopsy or FNAC of adrenal tumor is contraindicated. Okay, never do biopsy or FNAC. Okay, and we need to proceed for unilateral adrenalectomy if the tumor is unilateral. So this is the diagnostic algorithm once we suspect the Cushing syndrome. The first step is to confirm the diagnosis. Then we should differentiate whether it is ACTH dependent or independent. Once it is ACTH dependent, we need to differentiate whether the ACTH is from pituitary, that is Cushing's disease, or ectopic ACTH. So for that we need to do MRI pituitary, CRH test and high dose dexamethasone suppression test. If these are negative, it is ectopic ACTH. If they are positive, it is Cushing's disease. The treatment is pituitary gland surgery, transsphenoidal pituitary surgery, adenectomy. Okay. If it is ectopic, we need to do CT scan chest, or also radionuclide scan if necessary, to locate the ectopic source of ACTH. Okay, and if the cause is ACTH independent, we need to do CT scan of the adrenal glands to see for adrenal tumors. If there is bilateral adrenal involvement or micronodular adrenal hyperplasia, we need to go for bilateral adrenalectomy followed by lifelong steroid replacement, because if you remove both the adrenalins, the patient will end up in iatrogenic Addison's disease, right? So we need to give supplementation for lifelong, steroid supplementation. Whereas unilateral adrenal mass, we can do the adrenal tumor workup and we can proceed with unilateral adrenalectomy. Coming to the treatment of choice, removal of pituitary adenoma surgically in case of Cushing's disease is the treatment of choice, and usually it have 70 to 80% of cure rate, but the relapse is also common, hence we need to follow the patient for a prolonged period. And if tumor recurs, we can do repeat surgery, or we can do radiotherapy or stereotactic radiosurgery. Or finally, if none is working, we can do bilateral adrenalectomy. Coming to the role of medical therapy, usually before surgery we will give some medicines to improve the metabolic panel of a patient, because in severe Cushing syndrome the patient usually have uncontrolled sugars, uncontrolled blood pressure, and also dyslipidemia. So control that, we need to reduce the cortisol levels by giving some medications which are anti-adrenal gland drugs. They are metapropone, ketoconazole, etomidate, and also mitotin. So these are the anti-adrenergic drugs, in the sense they reduce the steroidogenesis by the adrenalins. Okay, and these are also used in patients with adrenal carcinoma, especially with metastasis, which are not non-resectable. Okay, coming to the recovery rate of HPA axis after treatment. Okay, the recovery rate of HPA axis is about 80% in case of ectopic ACTH patients, whereas only 60% with Cushing's disease, that is pituitary cause, and whereas in adrenal cause it is only 40%. There is one entity we need to know, which is Pseudo Cushing syndrome. This patient also appears Cushingoid, and also they have some biochemical abnormalities similar to true Cushing syndromes, like increased cortisol. Okay, the cause of this syndrome is severe depression, severe alcoholism, obesity, and polycystic ovarian syndrome. Okay, so how to differentiate between true and pseudo Cushing syndrome? We need to do dexamethasone suppressed corticotropin releasing hormone test, in which 0.5 milligrams of dexamethasone is given 6th hourly for 2 days, followed by CRH on the third day. After 15 minutes of giving this CRH injection, we need to measure the serum cortisol. If it is more than 1.4 microgram per deciliter, it is true Cushing's. Okay, if it is less than 1.4, it is pseudo Cushing syndrome. What is the treatment of pseudo Cushing syndrome? Treating the underlying disorder. Treating the underlying disorder will cure this pseudo Cushing syndrome. Thanks for watching. Please subscribe for more videos.